And good morning, good afternoon, good evening, wherever you are. And welcome to this WHO and TechNet webinar session on best practices in adult immunization. You can listen to this session in English, French, and Spanish. To do so, please click the globe icon, which is at the bottom of your window, and select the language in which you'd like to listen to this session. We'd be happy to know who's with us today, so please introduce yourselves in the chat box and tell us your name, where you're from. And you can also use the chat box if you have any technical issue, if you need technical support with the sound or anything. I'll be here to help you as much as I can. If you have any question during the presentation, you can use the Q&A box. So it's also at the bottom of your Zoom window. You can ask your question at any time, and our panelists will answer them during the Q&A session after the presentation. Finally, this session is recorded, and as usual, we'll share with you the links to the videos as well as the slide by email. I hope you'll enjoy this session, and I give the floor to Alba. Alba, the floor is yours.
Thank you so much, Alex. Welcome, everyone. Good morning, good afternoon, good evening. My name is Alba Vilajaliu. I'm a medical doctor, and I work at the Central Program on Immunization Unit at the Immunizations, Vaccines, and Biological Department at WHO headquarters. We'd like to welcome you to this second webinar on adult immunization. And this webinar is part of the series launched as part of the community of practice on adult immunization that we just launched in TechNet 21 platform and which is managed by WHO. This community of practice aims to foster collaboration, knowledge sharing, and also discussions among global experts and practitioners across regions and from different countries to advance adult immunization efforts for existing vaccines and also those in the pipeline that might become available in the coming years. If you're not a member yet, we would like to suggest that you register in TechNet 21 and join the community of practice on adult immunization. We'll share the relevant links in the chat during the webinar for you to be able to join. So having said that, what I'm going to walk you through is the agenda for today and what we expect to cover. The first thing that we're going to do is some opening remarks that are going to be by Dr. Anne Lindstrand, who is the EPI unit, so Essential Program Immunization Unit Head at the IVB department at WHO headquarters. Then we're going to move towards a quick poll. It's going to be a couple of questions and overview also of the work that has been going on mapping national immunization schedules with focus on adult vaccines. Then we're going to have best practices presentation from Argentina, followed from one from Ghana, and then also from another one on the evidence on COVID vaccination demand interventions to inform other vaccines, including mpox. Finally, we're going to have a Q&A session and a closing remarks. So without further delay, I'm just going to pass over to my colleague, Anne Lindstrand, for her opening remarks. Thank you, Anne.
Thank you, Alba, and good afternoon, good morning, colleagues and friends around the world. 50 years ago, exactly, more or less, in 1974, it was a pivotal year for immunization, when WHO founded the Expanded Program on Immunization, EPI, with its member states during the World Health Assembly. 154 million lives have been saved since then, mainly in children less than 5 years, contributing to almost 40% of a decrease in infant mortality in the last 50 years. Incredible progress with vaccination. The number of vaccine-preventable diseases has massively expanded since then. It was 7 in VPDs in 1974, targeting mainly infants, to more than 30 in 2024 for all ages, including adults. And the vaccine portfolio will continue to expand in the short and medium term. RSV vaccination for maternal and elderly adults was recently qualified and now is being used in more and more countries. The new TB vaccines for adolescents and adults will hopefully be on the market in a couple of years, and this will really be a game changer in global health. Now, the Immunization Agenda 2030, IA 2030, it's envisioning a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. So adult immunization contributes to this vision, maximizing health over an individual's entire lifespan. And we are in a world with an aging population. Right now, for the first time, there are more people above the age of 65 than there are children less than 5 years of age. And by 2030, at the end of IA 2030, almost 1 billion people will be over 65 years of age. So prevention will be very, very important. And as the portfolio of possible vaccines increases, we need to make programs ready to implement adult vaccination programs and make vaccination at every age a social norm. In addition, adult vaccination delivery platforms offer continuous health contacts opportunities to promote for synergies between immunization operations and other primary healthcare essential health interventions. Before the COVID-19 pandemic, public perception of vaccination had been more commonly associated with preventing disease and mortality in infancy and childhood, and national immunization programs, particularly in low and middle-income countries, traditionally targeted only infants, children, and women of reproductive age. So the COVID-19 vaccination was the fastest and most successful introduction of any vaccine in history. 99% of countries worldwide introduced COVID-19 vaccines within a year or a year and a half. And more than 13.6 billion doses were administered mainly to adults, reaching 89% of health workers and 84% of older adults. And this vaccination drive pushed countries to implement changes in policies, in attitudes, in demand, in systems, and massive vaccine experience, country experience was gained in vaccinating adults. Yet, in many countries, the rollout lagged because of the absence of strong platforms and use of adult immunization. So with this webinar series and the new WHO TechNet community of practice on adult immunization, we aim to provide a platform for exchange of experience between countries like today, Ghana and Argentina. I'm very curious to hear your experiences and knowledge around in this area and across regions for existing and new vaccines coming in the pipeline, targeting adults and contributing thus for a collective vision for immunization programs in the future. Thank you very much.
Thank you so much, Anne, for opening this webinar. So I'm going to move towards Dr. Victor Vega, who is going to do a quick poll before going into his presentation. Over to you, Victor.
Thank you, Alba. So now I'm going to show the first question of this poll. And we are going to give you some minutes to participate. I see some answers, which is good. So the question is, does your country or the country you work for include adults in the national immunization schedule? The options are yes, no, or not sure. So we have more than nearly 60% of participation. So now I'm gonna show the results. So let me know if you are able to see the results.
Yes.
Okay, so we see that 78% of the 45 participants said that the country includes adults, 16% said no, and 7% said that they are not sure. Now we're gonna move to the next question. Question 2. Sorry.
I think we're having an issue in terms of the question that it's being projected right now. So maybe Victor, you have to roll on to it.
So now you should see the question, right? Is if
Yes,
needed,
that's the correct one.
if needed, which source do you use to consult the national immunization schedule of your country or the country you work for? Is it the official government website? Is it from healthcare providers? Is it in social media, or you don't know? So we're gonna wait some seconds. Okay. So from 42 participants, we see that 79% consult the official government website, 12% to the healthcare provider, 7% to social media, and 2% said that they don't know. So with these results, now I want to move to that presentation. So the idea of this presentation was to show, to present a landscape overview of national immunization schedules with a focus on adult immunization. So next slide, please. So the idea was to map national immunization schedules to identify those that include adult vaccines. This with the aim to identify the current status of adult immunization worldwide as of December 2024. We want you to know that this project is a work in progress, and we would really appreciate your collaboration. So now I'm going to present the methodology that we use. So the idea was to find publicly available resources from the 194 WHO member states that present the national immunization schedules. And the sources were the official websites from the Ministry of Health, the National Center for Disease Control, or national health agencies that establish the vaccination policies. But we also leverage on existing tools that present or summarize some vaccination schedules, like the PAHO vaccination schedules map, also the ECDC vaccine scheduler tool from Europe, and the Vaccine Knowledge Project from the Oxford Vaccine Group. So once we review these sources and identify a national immunization schedule, we retrieve some data, basically the link to the resource, the year of publication, the format of this, that might be a table, an infography, or just a document, and then we define if that includes or not adults as part of the national immunization schedule. With that information, we built an interactive map using ArcGIS Online. Can we go to the next slide, please? Okay. So before showing this interactive map, I want to present on what did we find. So we found resources from 92 member states that are the 47%. And what we can see in this initial graph is the percentage of immunization schedules that we found by WHO or region. I want to mention again that this is a work in progress. So we found just 15% of immunization schedules for the Afro region, 57 for PAHO, 62 for Emro, 72 from Euro, 55 from Sierra, and 30 from Wipro. Among the 92 immunization schedules, we identified that 61% includes adults. And we see some differences based on WHO region. And we see that starting from Afro, nearly 50% includes adults. From Bajo, almost all include adults. The lowest percentage was seen from the Embro region. From Euro, more than the half of the countries include adults. And for Sierra and Wipro, it was nearly 25%, between 25 and 30% that includes adults. So now I'm going to present the interactive map that we have built. I'm now gonna share my screen. And now you can see, you should see a map. So this is the map that compiles all the resources that we have found on national immunization schedules. And we can see basically a classification based on if it includes only children, if adults are considered, it can be that the resource includes both children and adults combined, or if resources are presented separate, like for children and adults. The ones with gray are the ones that we have not retrieved information. So the idea of this interactive map is that once it will be made available, you can click on a country to retrieve the information regarding the national immunization schedule. For instance, let's look at Australia. So the idea is that you will be able to click on the country, and there will be a pop-up that showed information on the immunization schedule. In this case, for Australia, the resource that we found include both children and adults combined in a table. There you can see two links that can be used to access the resource. Those links are from and you can see now from the Department of Health and Aged Care from the Australian government. And in this case, you get a link to the National Immunization Schedule website. And if you click on the other link, you get the resource itself. So you can see the table that shows the different vaccination, like the vaccination schedules for different age groups, like in this case, childhood, adolescents, adults, and people with medical risk conditions. I can show an additional example. Let's say, for example, Pakistan. Again, in this case, for Pakistan, there are this immunization schedule only includes children, so no adults were not considered in this resource. And in this case, it's like an infographic resource. And we can see if we click on the link. So once it loads, you should see the official website, in this case from the Federal Directorate of Immunization from the government of Pakistan. And you can see the resource that we found that in this case is just for children. So having said that, the idea of this map, as you can see, there are many countries that are still needed to be completed. So I think I'm going to stop sharing, and maybe Daniela, you can share again the last slide. The idea is that if you have identified that your country is not represented here and you are aware of a national immunization schedule resource that it's available, you can make us know and please contact us. Here you can find the emails of both Alba and me. But also, I think we can make this consult through our community of practice. So this is what we have worked in order to map the national immunization schedules. And thank you very much.
Thank you so much, Victor. Again, I want to reiterate that this is a work in progress and we'd like this to be a joint effort. This is not yet publicly available. This is only, Victor has show it to you, but because we would like to complete it as much as possible. As it is right now, it includes information from 92 countries, but we're hoping that with the help of all of you, we will be able to complete it and increase the number of countries that reflects, and then we're gonna post it and make it available as part of the community of practice in TechNet. So if you have any comments or any reactions, I see that some of you have already started interacting in the chat. If it's a specific questions, I would suggest that you use the Q&A box. Otherwise, for comments or other reactions, you can also use the chat. So with that, let's move towards a country experience. In this case, it's my pleasure to introduce Dr. Gabriela Albert. She's a medical doctor. She works as part of the Directorate for the Control of Immunopreventable Diseases, DSA, in Argentina. And she's going to present Argentina's experience on developing and implementing an adult immunization, an immunization program that includes also adults. And she's going to focus on providing an overview as well as then on influenza vaccination for adults, pneumococcal disease vaccine against pneumococcal disease vaccination, as well as the recent introduction of maternal respiratory syncytial virus vaccine targeting pregnant women. So thank you so much for joining us today. She's going to be presenting on Spanish. So please, if you need translation, Alex has provided guidance, but otherwise you can also put it in the chat and Alex will help you. Thank you so much. Over to you, Dr. Albert.
Hello, good morning, good afternoon, good evening. From the Ministry of Health of Argentina, we wanted to share with you the experience of Argentina in the development of immunization for adults. The case of Argentina has changed a lot and developed a lot in the last years. It has gone from vaccinations based mainly on children and infants in 2003 with 11 antigens. And nowadays, it includes vaccines for all ages throughout the years. And nowadays, we have 20 antigens. This process also considered having a lot of protection, the use of combined vaccinations. We always took into account problematic issues, scientific evidence, and of course, international recommendations. Next slide, please. The vaccination schedule is complex, wide range, and it includes all stages of life. It's important to highlight that vaccinations in Argentina are free and compulsory. The state buys them, and they are available for free for the whole population that is subject to them. Here I wanted to show you some infography that is available in the ministry webpage, in which we see all the ages in which we have vaccinations. Next slide, please. Now, how do we arrive to all these changes and how do we carry out this process? The idea to include a new vaccination or to change the calendar starts in the immunization program the country, where we consider the political priority, we analyze evidence, the disease burden, the availability of efficient and quality vaccines. We compare the vaccination strategies to other available strategies. We assess cost and effectiveness, and then we talk with the work group. The work group has two coordinators. One is from the direction of immunopreventable illnesses and from the for another immunization coordination. Once this organization, La CUNAIN, meets and takes a decision, and they make recommendations, but they are non-compulsory, as this is external to the Ministry of Health. So the ministry can implement or not, or maybe implement them in the future, but La CUNAIN only gives them recommendations. And once the ministry decides to buy a vaccination, the state buys them and distributes them in all the provinces of the country. The vaccination is done by the jurisdiction in each of the provinces, and the decision is shared with ministers of health in COFESA, which is the Federal Council for Health, where all the provinces of the country are represented. Law 27,491 is from prevention of illnesses that can be prevented with vaccination, and has a lot of information regarding vaccination. And this law says vaccination is for national interest, that it's a health strategy, that is preventive, and that it's highly effective, and it says that it's a social good, and it should be free of access for all citizens. And it is also saying that global health is more important than personal interests. Now, we are going to specifically see vaccination of adults. Here is a slide on vaccination on pregnant women. In the year 2009, as you'll remember, there was the pandemic of H1N1, and there was a huge impact on mortality for pregnant women. And there was a huge impact. So in the year 2010, once we had the vaccine for the first time, we decided to carry out an anti-flu campaign. And the following year, in 2011, this vaccine was included in the schedule. So this meant that it was already available for free for all pregnant women. So from that time on, all women who are pregnant receive flu vaccine at any time of their pregnancy. In 2012, it was recommended, and in 2013, the vaccination against pertussis was introduced from week 20 on for all pregnancies. The decision was taken after having seen a huge increase in mortality due to pertussis in pregnant women and children who were breastfeeding. So this is why we decided to continue vaccination with pertussis. We saw an 80% decrease in death in infants due to this. And it was in 2012, and then it was that was recommended, and 2014 when it was implemented, that we had a vaccine for HBV. The pregnancy is a good time for testing, so now the vaccine is available in case pregnant women need it. As you all know, the COVID pandemic that reached all of us in December 2020, we had to vaccinate people, and we created a vaccination strategy. And then in 2021, once we saw evidence of the impact of COVID-19 in pregnant women, we decided to vaccinate all pregnant women in any stage of gestation. And this continues up to now. One more. And lastly, we have a last introduction, the vaccination against RVS. So it's for all pregnant women between 32 and 36.6 weeks of gestation. As you know, Argentina is one of the first countries in the world to include this strategy, and the first one in Latin America. Now, just focusing on vaccination of adults in general, I would like to highlight that for our adult groups, there are vaccines that are available in the national schedule for immunization of the country, and all of these are available for free. Each consultation is an opportunity to check the vaccination schedule and complete them. All adults need to have 2 doses of DT, and if they don't have it, or if they haven't responded to it, every 10 years they get the hysteria and tetanus vaccine. And we also have universal vaccination against hepatitis B. And apart from these vaccines, for personnel, there is the flu vaccine and some others that we can see there, depending on the activities carried out by the health professional. For example, for people who are in microbiologic labs, they would get the DTP-ADT vaccine. And for example, for risk groups, depending also on the kind of risk, we have the flu vaccine, the pneumococcal vaccine, and for example, in some groups, for example, we might use the influenza vaccine or the DTP-ADT or the AB hepatitis vaccine. And for those over 65, we have a yearly vaccination against the flu and pneumococcal. Apart from these vaccines that are in the schedule, we have recommendation of vaccination against COVID-19. And in one of the last meetings in the Immunization Directorate, it was decided and recommended to the Ministry of Health that this vaccine be included in the national schedule of immunization. But up to now, it's still a recommendation. It's not included, and the current indication is from 6 months of age on, with reinforcement every 6 months or 1 year, depending on the age group. Regarding flu vaccination, as we were saying, the objective of flu vaccination is to reduce complication, hospitalizations, and death caused by influenza. The population, the target population is pregnant women, people between 6 to 24 months old, and people from 2 to 64 years, and those 65 years of age or more. Here we can see our experience vaccinating for flu that we introduced in 2012. Here we see the bars for health personnel. And in blue, we can see the year 2020, when we still didn't have vaccines against COVID. And the health personnel was asking for at least flu vaccines. That is why there was an increase. But then if you take a look at the following years, like 2021, coverage reduces because we didn't have the indication of what to administer with COVID. So COVID vaccines were prioritized, and the group 1 was done a bit later. But for some time there was co-administration. In the next one, we see vaccination in pregnant women, and this decrease that might seem a decrease in the group is that we now have a different denominator. In 2018, it was it was about 60% what we considered, but it actually was maintained constant. It didn't really happen as it might seem in the graph. Regarding the people that have risk factors, we don't have a denominator, and that is why we talk about applied doses. And we can see that the demand in 2013, 2020, 2016, there is a great demand of vaccination because there were more virus those years and more mortality due to the flu. And in adults who are over 65, we should mention that we are increasing the doses year by year. Regarding vaccination against pneumococcal, what we wanted to show is the dynamism of the strategy and how we have polysaccharia vaccine, and then we had evidence and more availability of other vaccines. So we changed our vaccination strategy. At first, we had the PCV13 and PPV23 vaccine initially for children, but then for 2024 we changed to the 21, and in 2025 it will be also for infants and for people at risk. Regarding population that has respiratory issues, as I was saying, we have introduced a lot more vaccine for this to try to reduce death of infants due to bronchiolitis. We started in March and we finished in August, and we managed to get a very high coverage. Remember that it was the country that decided to do it between week 32 and 36 of gestation. The following year, the National Immunization Commission decided to start a bit earlier in January to be able to reach more population that was 6 months gestation during the flu period. And something that was alarming regarding this vaccine was premature infants being born premature. And here we see the percentages, and this is less than the rate that we expected for premature, that is usually about 9% of pregnancies. And we also need to highlight that 85% was late early pregnancy. We also wanted to share this poll. It's the nutrition poll, and the Ministry of Health did it, and there were thousands of polls done throughout the whole country. And regarding vaccination, that's one of the things we assessed. We mainly considered maternal vaccination, adolescents, and adults. What we saw is that when they asked them why they vaccinated themselves or why they didn't, the factor due to which they access the vaccine or not was due to medical indication or lack of medical indication. So this is why we concluded that it's important to work with health professionals for indications with the whole medical team so that we can promote vaccination. And the last conclusion, final consideration, is that Argentina has a vaccination schedule that has vaccinations that are secure and free, provided by the government, and the process of decision making is based on scientific evidence, is transparent and dynamic to adapt to all changes that occur. We want to highlight the commitment of all the sectors of the health and different scientific societies, as well as the whole health team, to manage to get the highest coverage. Our objective is to empower the population so that they demand vaccination. Thank you very much, and we are available for any questions later. Thank you.
Muchísimas gracias. Thank you so much. This was a really comprehensive presentation, and it's really impressive what you have achieved, and the fact that you also highlighted that your immunization program is dynamic and it's evolving as per the needs. And the fact that you have demand from adults, this is certainly also something to highlight, and the trust on vaccines for existing program and for the future. So I'm seeing that there are starting to be questions in the Q&A box. So I would say, if possible, if you can start addressing them, you can address them in Spanish, and then we're gonna support to translate them in English or French as needed. So having said that, we're going to move to our next presentation. In this case, we're moving towards another region. In this case, is from Ghana. And we have Dr. Tanko Nazaro Mohamed, who is the Deputy Program Manager at the Ghana Deputy Program Manager of the Expanded Program on Immunization at the Ghana Health Service. So he's going to be presenting on behalf of the of Ghana on leveraging COVID vaccination lessons for adult immunization in Ghana, use of geo-enabled digital microplanning for vaccine delivery, and with a focus on what they did during COVID for COVID vaccination, as well as how they are sustaining that for strengthening routine immunization services. So thank you so much for joining today. We're looking forward to your presentation. I'm not sure if Dr. Tanko can hear us. Otherwise, what I would suggest to maybe we move to our next speaker, Dr. Chizoba Bonode, and we go to the next presentation, and then we'll come back and in the meantime try to fix if there are any IT issues with our colleague from Ghana. So yeah, then it's my pleasure to introduce Dr. Chizoba Bonode, who works as part of the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. So Dr. Chizoba, it's also a pleasure to have you here and to present us on the results of a COVID vaccination systematic review that we have been working together, WHO, as well as IVAC, so Hopkins, as well as Duke University, and trying to understand how we can leverage the lessons of demand interventions that were used during COVID vaccination for other vaccines, including to respond to other emergencies, as it is the case of mpox. Thank you so much, Dr. Chizoba. Over to you.
Thank you very much, Alba. Good morning, good afternoon, good evening, everyone. It's a pleasure to be here. Like Alba said, I'm going to be talking about a systematic review that we've been working on to pull together evidence on demand generation activities for COVID vaccine that could be used in future. Next slide, please. So Anne has done a really good job with the introduction. So I just want to be brief here, just to say that, in terms of COVID vaccination, there's a lot we can learn about the rollout and how countries that were able to achieve their coverage targets overcame both demand and supply side challenges. And so this is the work that we're doing with this literature review. Next slide. So for this literature review and for this presentation, I'm just going to focus on a couple of questions that we've been asking. The first one is, what types of demand generation strategies were employed and tested to improve COVID-19 vaccination globally? This review is covering all the countries in the world. And the second question we're asking is, how effective were these demand generation interventions on vaccination outcomes, and what lessons have been learned? And we will try to draw some lessons for mpox vaccination, since it is an urgent matter today. Next slide. So our methods are standard systematic literature review methods. We started by developing a conceptual framework. So this presentation is focusing only on the demand aspect of a broader literature review that we're doing. Other elements of the review include, 7 other health systems building blocks, but I'm just focusing on the demand aspect. So we had a standard approach of developing our search strategy. We searched in 3 databases listed here. And the types of studies that we included were studies that were designed rigorously, either RCTs, randomized control trials, before and after intervention trials or quasi-experimental studies. We had other inclusion criteria, but one exclusion criteria to mention is that we wanted to limit the review to studies that had numeric outcomes. So if there were no numeric outcomes like coverage or odds ratio, they were not included. Our synthesis is done narratively, and we're using the COMVAX taxonomy of communication interventions as one of the frameworks for our synthesis, and in addition to inductive synthesis of the themes that emerged. And, we managed this on COVIDence. Next slide, please. So for the findings, I'm just going to focus on where the studies were done, what the study designs were, the main outcomes that were measured, types of interventions, which is the key interesting part of the presentation, and then effectiveness of the interventions. And then we'll draw some lessons for mpox. Next slide. So what we see here when we mapped all the studies was that majority of the studies were done in the US. About 50% of the studies were done in US, but 27 countries are represented in this review. Interestingly, there was no study reported from South America. So in terms of the representativeness of the findings, that is one thing to keep in mind. Next slide. So based on our inclusion criteria, most of the studies that we included were either randomized controlled trials, quasi-experimental trials, or pre-post interventions. And then in terms of the outcomes that were measured in these studies, most of the studies, or rather the majority of the outcomes, were really vaccine coverage. Only 5% of the interventions measured odds ratio, and the implication is, the difficulty with doing meta-analysis when you have few papers reporting odds ratios. Next slide, please. So here, what you're looking at is a tree map, as they call it. What we try to do with this map is to describe the interventions that were designed to inform, educate, or recall and remind people about vaccination. So like I said, we use the communication taxonomy, and within it, they describe interventions to immunization interventions have different intentions. So it's either you want to inform, you want to educate people about it, you want to remind people, or you want to get them to recall. So what we see here is that most of the interventions that were reported across the different studies were actually designed to inform and educate. So these are communication interventions. We also see that there were other aspects of the interventions that were trying to enhance community ownership. And then there were also interventions that were trying to enhance access. You will see a bit more on this later on when we dive deeper. The main takeaway from this slide here is that majority of the interventions were communication interventions designed to inform and educate. Next slide. So we looked at those interventions that were designed to inform, educate, and remind and recall, and broke them down by the types of strategies that were used. So we see that for the most part, these communication interventions were interpersonal communication. So either a provider speaking to their clients, that has been mentioned before, or it's community-based approaches, but by far the most frequently used approach to communicate information is interpersonal. And there were also interventions that looked at using pre-scheduled appointments to remind and nudge people about their vaccination. Next slide. So here we see some specific examples of what I was just talking about, right? So for example, interpersonal communication that was reported in several countries. You have door-to-door visits by community champions to deliver COVID-19 vaccination education to elderly people in Tanzania. So that's one thing to draw out for adult education. And then you have for printed materials, were also used quite commonly in terms of visual aids and IEC materials used as flyers during community outreaches. For phones, you can think about some innovations around leveraging technology. So there were some interventions that used the phone where case managers answered questions about vaccine safety and side effects using their phones. And then, of course, there is the bulk SMS outreach reminders that are used in several countries. Next slide. So just to mention also that mass media advertisements were also very popularly used, radios, television, even social media. There were some examples using the mass media to communicate and inform about the vaccines. Next slide. Okay, so again, these are more examples that you can look at later. Recall and reminders, like I said, things like scheduling appointments were sent through mails, text messages to provide information on how to schedule vaccination, and then using press releases to remind people on timely vaccination. So there are a variety of platforms that can be used to remind and recall, as we saw in the review. Next slide. So moving a little bit more, when we look at other types of interventions, so I kind of color-coded it here so that you can see additional approaches. So there were some interventions that were designed to enable communication. So those are the ones in blue that we found. So for example, if language was a barrier, providing interpreters was a way to enable communication and get people to take up the vaccines. Another example is the one called translation beyond routine practices. So for example, these were done when people had disadvantages or blind people who could not read. So providing Braille readers for them was a way that providers could go above and beyond to enable communications and get people to uptake vaccinations. And then I wanted to point out that the one in purple, one other approach is to enhance community ownership. So this is not just to improve demand, but it was also seen as a service delivery approach or improving services. So here we involve the communities in designing the vaccine approaches. We engage, we saw that they engage local leaders to ensure that the strategy that was put in place was actually appropriate for the community. Next slide. Okay, so we also found some interesting approaches. So approaches around mandates and incentives. Here we see that there were about 7 different studies that talked about incentives, either providing cash or doing a lottery or providing gift cards and other services just to get people to come and receive the vaccines. On the flip side, so you can consider the incentives as carrots. On the flip side, you also had some interventions where there were mandates. So this was policies insisting that if people were not vaccinated, then they could not have access to, say, restaurants or things like that. And then, interestingly, there were some studies that used mandatory tests as a way to get people to be vaccinated. So they didn't insist that people get vaccinated, but if you were not vaccinated, then they mandated you to do tests regularly every 2 weeks. And that was evaluated as an intervention to improve vaccine uptake. Next slide. Okay, so this is just what I talked about, so we can skip it. Let's go to the next slide, please. So finally, we asked ourselves, all these interventions, how well did they work? We did a general, like a qualitative assessment of the outcomes that were reported. So it's not a meta-analysis per se. So we just asked in terms of the data that was reported by the papers, were there positive findings? Did the authors report that there were positive findings or positive impact of the interventions? About 50% of the papers that we looked at reported on, whether or not there were findings. And what we then did was that of all the papers that adopted any of these strategies, we then looked at what proportion of those papers reported positive findings. So that's the slide you're seeing here. And what you can see is that Remind and Recall was the least, had the least proportion of studies that had positive findings. And then community vaccination outreaches and mobile vaccination units had almost 80% of the studies reporting it had positive findings. So that's how to interpret this graph. Next slide. So what we see from our review is that, first of all, interventions to improve COVID-19 vaccination uptake included communication interventions. That was the staple. And most of the intention with this communication is to inform, is to educate people about the vaccination, is to get them to remember to either either book for vaccination or come in for vaccination. It's also to enable them to communicate if they had a language barrier. There were also some interventions that were geared towards facilitating people making decisions to take on the vaccine and then providing practical support for them. Most of the demand generation interventions were not implemented alone. So it were very few studies where it was just one strategy that was used. So if there was interpersonal communication about vaccines, there was usually something else, either a flyer or text message reminder. So the key thing here is that these interventions were used in combination. We also noted that while there were several studies that had only purely demand side interventions, many of the studies combined the demand side interventions with service delivery. So things like community outreach, mobile vaccination. And if you recall in the previous slide, you could see that mobile vaccination community outreaches had the sort of higher impact because they were, for the most part, they were combined with both demand and supply side interventions. And then there were some programs that made programmatic enhancements by removing practical barriers for to access to services for vulnerable people. Next slide. So another thing we noted was that the communication interventions to inform, educate, and remind, as well as to recall, were the most commonly reported types of intervention. And then for the most part, interpersonal communication was most frequently used as a means to communicate. So good old conversation between doctors and nurses, good old discussion, in the communities, champions, those are the staple for informing people about vaccination and encouraging them to get vaccinated. So, but while communication interventions were most common, they were actually the least effective. So if you looked only at the communication interventions, you found that the number of studies that reported positive findings, or the proportion, was less than the proportion of studies that included the service delivery component, and actually reducing access to vaccination by going to the communities. So what we then see that is that interventions that combined community vaccination outreaches and also enhanced community ownership were most likely to produce positive results. So the implication here is that when we think about demand generation activities for adults, so we see that adult vaccination platforms are not very well established in many countries, particularly in Africa. COVID is kind of the first more broadly more broadly targeted adult vaccination that we have. So it has to have a combination of both the demand side as well as the supply side. And particularly if we're looking at older adults, looking at how to ensure that we remove access barriers by perhaps going to the communities with those vaccines, doing outreaches, making outreaches a very strong component of the immunization strategy. Next slide. So in conclusion, the piece of the review that we've looked at, it leads us to think that interventions to improve vaccine uptake should take a comprehensive view that includes addressing not just people's perceptions, norms, and motivations. When you think about the social behavioral drivers, those are important to address, but we should also be sure to address practical barriers that may hinder people's access to vaccination. Thank you very much. I think this is my last slide. Next slide, let's see. Yeah, so just to appreciate WHO for funding this work and overseeing its implementation in true partnership, and my colleagues at IVAC, Duke, and DCL for their partnership in this project. Thank you very much.
Thank you very much, Dr. Chisova. I think we learn a lot, and if I can summarize in 2 words what you have been saying, is that my take-home messages were combination of strategies as well as engaging with the community of the findings based on the evidence that has been published since in terms of COVID vaccination since December 2020 to date. So thank you so much. I would encourage the participants to post any comments, questions in the Q&A box. And now we are going to move. We have Dr. Tanko Nazaru Mohamed, Deputy Program Manager of the EPI program in the Ghana Health Services. I understand that he's ready. He had some connectivity issues, but it seems that now they have been solved. So over to you, Dr. Tanko.
Yes, thank you very much, Alva. And greetings to everyone on the call. Sorry for the initial challenges, but we are back online. We are very glad to be given this opportunity to share our experiences around adult immunization in Ghana. So without taking much time, if my slides can be put up for me, please. Okay, so we'll be sharing our leveraging the COVID-19 vaccination lessons for adult immunization in Ghana, the use of the geo-enabled digital micro-planning for vaccine delivery. And by way of the overview, the Ghana's EPI aims to protect our population against children and pregnant women, against vaccine-preventable diseases through free, decentralized immunization services that is integrated into primary healthcare. So generally, all our vaccines within the expanded program on immunization are offered for free. We have a very decentralized system up to the community level, and the immunization program is delivered through that. Just some historical perspective to the program. We launched the EPI in Ghana in 1978, 4 years following the global launch in 1974. Currently, we are vaccinating against 14 vaccine-preventable diseases using 11 vaccines. And I must say that one of the vaccines is is targeted against pregnant women in the form of tetanus diphtheria. And so that is the vaccine currently that we are using as, to target the adult population. The rest are mainly children. The other, following the COVID-19 pandemic, is the COVID-19 vaccine. And so we've chosen that to share the lessons or our experiences. The main strategies we've been using to deliver these routine vaccines are the static outreaches, mobile teams, then mop-ups, and then the campaigns periodically. I must say that the adult population are also targeted occasionally during campaigns when there are outbreaks. So yellow fever, then the menafric or the meningitis vaccine is used sometimes in adult population. And then sometimes measles up to the age of 15, sometimes we do that. But in routine, then I would say it's the TD, the tetanus diphtheria, and then the COVID-19 vaccine. Next slide, please. Okay, so zooming into with the COVID-19 vaccination, Ghana initiated the COVID-19 vaccination in a form of a campaign from the 1st of March 2021. And I must say, we were the first country to receive the first doses of the COVAX, vaccines from the COVAX facility, about 600,000 doses that the country received. And because of the limited supply, we had to actually do or deploy these vaccines in a phased manner, initially targeting children or the young adults from 18 and above, later with the guidance of the National Immunization Technical Advisory Group, and improved cold chain facility. We're able to scale it down to 15 years and above, including pregnant women. And as at September 2024, approximately we've been able to reach almost 56.6% of the total population with fully vaccinated, that are fully vaccinated with their primary series. And then about 71% haven't received at least one dose of the vaccine. We use different strategies to be able to reach out to this population, especially initially with the limitation of the vaccine. We had to target high-risk groups, which with the guidance of NITAG, we were able to segment the healthcare workers, then the population 60 years and above, then persons with underlying medical conditions. When the vaccines actually supply improved, then the general public was brought on board. And generally, as you can see, the uptake or the vaccine coverage has been very encouraging, and using multifaceted approaches and strategies, we've been able to reach out to the target population. And so the innovation that came along the line, or we use along the line, to also help in terms of the deployment of the vaccine, is the use of the digital tools to help us in micro-planning the vaccine delivery, though this time around in adult population mainly, but it's had some actually important lessons for us to learn from, with the understanding or with the view that the country currently is even preparing to introduce the HPV vaccine, the human papilloma virus vaccine, which is targeting or will be targeting young girls from 9 years to 14 years. And traditionally, they are not a target group within the our routine immunization schedule. And so with these lessons, we know that it's going to help improve whatever approach we are going to use at the end of the day to reach this target population too. So with the use of the GIS mapping tool used at various levels, we were able to enhance efficiency in the COVID-19 vaccine delivery. So when at the point of micro-planning, we use it in visualizing our population density, and then look at where the geographic barriers are to improve the vaccine effectiveness or campaign effectiveness. And we're able to use it to also map the health facilities, the outreach sites, such that they are not above 5 meters, to ensure that at least there is equitable distribution of these sites where the vaccination centers are actually sited, to ensure that access doesn't become really a major barrier in the vaccine delivery. So we, with the support of CHAI, we were able to identify some 4 regions within the 4 regions prioritized at about 16 districts to use this geo-enabled micro-planning to improve our vaccine delivery efforts. I think we can go to the next slide. Yes, I know we are working within some limited time so that we can have some questions coming in. And we use about 4 or 5 main criteria to make the selection, looking at the vaccination coverage in these regions and districts, the disease prevalence in these districts, then the adult population and the proportion of the population that had not been vaccinated yet. And using the various criteria, we're able to identify 4 regions, and within these 4 regions, 4 districts were selected in each of these regions to build their capacity for use of these geo-enabled digital micro-planning. These geo-enabled tools to develop effective micro-plans for the vaccine delivery. So what were some of the lessons that we can share with colleagues? Next slide, please. Good. So on this slide, we're showing how some of the outputs that our officers were able to churn out with the support of CHAI and the Rockefeller Foundation, a grant that was secured. So the first map you see there showing us the coverages that previous campaigns had covered, and then the post training, we use it to inform the development of the micro planning, where the effort should be actually concentrated to ensure that we are able to bring those sub-districts and districts that are below, performing below expectation, and bring them up to speed. We're also able to use it to identify the hard-to-reach areas, and then map out strategies, forming special teams to be able to target these populations using real-time geo tools to be able to do that. In Ghana, there are some populations that, we have migrant populations. Today, they are concentrated at a point, and the population is very fluid, moving from one point to the other, especially the nomadic populations. So with the use of these tools, at least as the vaccination effort progresses, and then the population, these migrant populations, to keep on changing from one point to the other, we're able to track them in real time. We're also able to use the digital tools to identify the coaching equipment that are available within this district, and then map them out and see how we can best situate them so that, at least in terms of the vaccine distribution, how we are going to ensure that we are able to get these vaccines transmitted or transported to various facilities and to the last mile, i.e. the vaccination centers. In Ghana, we are using these drone technologies with the support of Zipline. So wherever we know that there are challenges, we call them in ahead of time so that they support in the vaccine distribution using these tools. Next, please. Yes, on the right, we are still demonstrating some of the outputs from the training and how it actually helped us, our officers on the field, to improve on the their planning that they conducted at the various districts and facilities. Next slide, please. Yes, so by way of the lessons, it helped improve the precision in targeting the population, as the GIS tool enabled the identification and mapping of high-risk groups, the underserved areas, and the vaccination site. When these are already pre-identified ahead of the campaigns that we actually were using as the main form or the main strategy in the vaccine delivery, it helped us plan ahead of time, target the groups that the interest is, and then deliver the vaccines to them. It also enhanced the resource allocation that we had. Always the limited resources that are available is at the back of our minds, but when the planning itself is enhanced or improved, then we know where should we channel what. In terms, initially I made reference to our cold chain equipment. We know a lot of our facilities are not having the cold chain equipment. And with these improved tools, we are able to identify them, know where they are situated, where the gaps. We work towards bridging them, but during the campaign, then we know whether we needed to move them from one point to the other to ensure that at least we are able to improve the distribution of vaccines within the catchment area. Then it was also able to streamline the campaign planning and execution, then the real-time monitoring, and then feedback. So with this in mind, during the campaigns, teams were on the field to help us monitor how the as it were the delivery is going, where we are not able to serve a particular geographic area appropriately. We are able to pick it up because the locations are picked by way of rapid convenience monitoring. And then when these are mapped, we are able to know where or which areas are really not being served appropriately, the underserved communities and population. And then quickly we are able to adjust to reach out to them. Then the integration of the digital reporting tools will help us at least reduce errors and improve the accountability in data collection. These are real time. So if there are officers on the field that are not really working, we are able to pick it up quickly and then institute measures to ensure that we get them to work where they've been assigned. It also helped us in improved collaboration and coordination. Because we shared the GI maps and digital systems, it facilitated the coordination among our various agencies, the health teams and partners, streamlining decision-making execution so that as the campaigns went by, currently we've done about 11 of such campaigns, but we started using it pretty much early during the campaign period. And as we progressed, then we use the information to improve on subsequent campaigns that we actually are conducting. And the tools actually provided a unified framework for planning and evaluating campaign success because we see them in real time. And then during the post-campaign review meetings, we're able to demonstrate or share with the healthcare workers themselves and all the stakeholders how far we are progressing and where we are lagging, we use it to improve the subsequent planning. In terms of scalability and sustainability, it looked very promising because the tools that we are using generally are free tools that we can get online. We have committed partners that are helping us, that have actually shown that they are ready to support us. We have demonstrated that it is actually helping us improve the vaccine uptake. And in fact, even in terms of routine immunization, we are scaling it up to ensure that these knowledge and skills that we are building is not only limited during, use only limited during the campaigns. So now when you visit most of the districts, there are plans that we have for routine immunization. You see elements of the use of the digital tools to identify the underserved population and underserved the communities to reach our target population. Yes, we have some challenges in the form of the funding to ensure that we are able to scale it up. Ghana has about 16 regions, and so far, if we've been able to work within just a limited number of regions and districts, it means that there is more for us to do as a country to actually unlock the full potential that the digital micro planning tools offer us as a country. And so we are hoping that we'll continue to collaborate with our partners to ensure that we are able to sustain and scale up what we have started doing. Thank you very much. I think we'll end it here and then invite our questions or contributions from our audience. Thank you so much.
Thank you so much, Dr. Tanko. I think the last two words that you said are particularly relevant, the scalability as well as the sustainability for what was generated as an innovation during the COVID period when it was a pandemic, then it was sustained for COVID vaccination, and now thinking also how to leverage that for routine immunization programs, including adults. So thank you so much. We have now 7 minutes that we are gonna have like questions and answer session. And then I have seen that there is someone, Christabel Soyen, that has been patiently waiting, raising his or her hand. And I would like just to invite to provide his or her question. Thank you.
Christabel, you can unmute yourself and speak if you want. Your sound doesn't sound good. Are you here, Christabel?
So maybe it's not a real hand. So I would say that if anyone would like to make a comment or question, please raise your hand. Also, thanks to the panelists who have been already addressing most of the questions in the Q&A box. At the same time, since the questions were asked in different languages and the response was also provided in different languages, I would like to use this opportunity to highlight a couple of questions, for example, that were asked to Dr. Gabriela Elbert, in terms of clarifying if the vaccines for adults are mandatory. There was a question from a colleague from Duda Sampara from Mali. And also there was a question, I think in this case was from Dr. Emmanuel, that asking also how vaccination for adults is provided, if it's provided at the same time by the same healthcare providers to adults and children, and how this is happening at the health facility level. So over to you, Dr. Gabriela.
Yeah, the vaccinations that are in the calendar are compulsory, and we have recommended vaccination. For example, for risk groups, they are available, but they're not compulsory. That is the big difference that we have in Argentina. When vaccination is in the general vaccination, calendar, it becomes free and compulsory for everyone. And the second question was if it was in the same place. Yeah, it's the same place that children, adolescents, and adults get vaccinated in. Of course, for some groups, there are additional strategies. For example, in the case of children and adolescents, there's vaccinations in schools, but all vaccines are available in the health center, and it's the same place for everyone.
Una pregunta adicional, sorry, I'm just going to change to English. So an additional question about that. For example, for pregnant women, when pregnant women, they go to their follow-up, pregnancy follow-up visits, how is vaccination provided? Is the pregnant woman going to, the next door and getting the vaccine, or it's the midwife or whoever is doing the follow-up providing the vaccine? How is this happening? Thank you.
Health in Argentina is divided in 3 subsectors: public system, social security, and private system. And they work differently. Usually in the public system, where we have all the vaccines and vaccination calendars, which are the vaccines that are given by the state, they try to coordinate to make sure that the vaccination centers are close to where pregnant women or children would be going to the doctor, so that it's available and accessible. But in the private sector, it's the doctor that gives the indication, and the person will need to go to a public or private vaccination center to receive the vaccination. But it's not organized in the same way everywhere.
Thank you so much for clarifying, and also for addressing those questions that were specifically related to you in the chat or the Q&A box. I'm checking if there are any hands. So I'm not seeing any hands, but I still see some questions. And one was for Dr. Chisova, and it was about There it says that further, a lot of miscommunication was attached with COVID vaccination. Can we discuss the best communication strategy to counter the misinformation? So I was wondering if you have any insights based on the review of the evidence on how to address that for COVID or for, I think, for other vaccines that could be leveraged.
Yes, thank you very much for that. I think the first thing to note is that each community is different, right? Each community is different, and it's usually better or good to understand the particular rumors or misinformation that is circulating in a community. That's the first thing. The second thing is that there are different trusted messengers. Different communities will have different trusted messengers. In many countries in Africa, for example, the people they trust are either their religious leaders or their community leaders. So if you work with the religious leaders or community leaders and get them to understand the benefits of the vaccine, they can be champions. So there were studies that used champions. There was a study in Tanzania that used champions to address vaccine rumors and disinformation. And in addition to addressing the vaccine rumors and disinformation, that study described home visits and house-to-house vaccination of people. So that's the first thing. Then the second thing is that we see that the way a message is framed is actually important. There was a study in Saudi Arabia that sent out different types of messages so that they were framed in 5 different ways. One was framed as addressing the ego. Another one was framed as addressing social norms. And what they found was that the messages that were framed around social norms or peer pressure worked better with younger people than with older people. So the point here is that there's not one answer that fits to every community. We have to understand that community. We have to tailor the approaches that we use to address rumors for each community. Thank you.
Thank you so much. And with that, we're just right now at the end of our time of this webinar. What it's going to happen now is that Daniela, who's the community manager of the community of practice in TechNet about adult immunization, is going to share in the chat the link. For those of you that you're not yet registered in TechNet, this is a website that it's managed by WHO with collaboration with many partners. And it's a network of immunization people who work in the immunization arena. It has more than 6,000 members, and it's also a way that we can facilitate sharing information about different topics. In this case, we created a specific site for adult immunization. So we encourage you to register. We are really pleased with all of you joining us today. Our next webinar is going to be in a couple of months in Q1 2025, and we look forward to continue engaging in this conversation and about how to strengthen routine immunization programs, including vaccines targeting adults. So thank you so much to all of you. We're going to share the recording as well as the slides, as well as relevant links for you to be able to join the community of practice. Thank you so much and have a nice day.
Thank you. Bye-bye.
Thank you, everyone. Bye-bye.
Thank you.